Great. So once again, thanks for the invitation to speak at this important event. I do have fond memories of doing similar talks back in Australia to our local PCF Australia support groups. So it's lovely to be in this environment again. Very interesting hearing you talk about having a little session at the start about the new papers that are emerging in prostate cancer. And I will be touching on lutetium treatment. I was very lucky to be at the right place at the right time when this all started at the Peter MacCallum Cancer Centre in Australia down in Melbourne. So I remember seeing a number of patients back when the treatment was very experimental, and to watch that grow over the last 3 to 5 years has been extraordinary. But that's going to be for the back end of my talk. So today's talk is going to be about treatment advances in advanced prostate cancer. Focusing on when the disease is still sensitive to hormone therapy. Let me just make sure these slides are working okay. So if you haven't already figured it out from my accent as well as the introduction, I am from Australia. I grew up there all my life and grew up in sort of northern Australia in a place called Gold Coast or Brisbane. It's where I did medical school. A lot of people go there as a holiday destination, as you can see from the picturesque views there, pretty stable temperature all throughout the year. And then after medical school, I moved down to Melbourne, trying to get a bit closer to where some of the major medical advances were being made. Brisbane is a great place to live, and obviously my family is there, but at the same time, Melbourne is, and Sydney, for example, are the major capital cities in Australia. Some of you may have travelled there in the past, and they are at the forefront of not just national research, but also global research, and especially in lutetium PSMA. So a few disclosures. As Norm mentioned, I am a practicing medical oncologist back in Australia, and my main focus back there is on genitourinary cancers. So I mainly see prostate cancer patients, probably make up a bulk of 80% of my practice, but I also have an interest in kidney cancer. After I became an oncologist, I did some research that looking at DNA and RNA in the blood to predict outcomes specifically in prostate cancer. And you've had some great speakers here in the past. I was looking at, in the next month, you're having Cameron Herbert's come back after giving a great talk last year, Lucia Nappi, a lot of other speakers who will have far greater knowledge in this realm. So that's not something that I will go into too much depth about today. And I guess the final disclosure is that I am not currently a practicing oncologist in Canada. Hopefully that's going to change in July this year. But what I won't be touching on is access to drugs. Maybe that's something that we can chat about from an audience point of view in the back end of the talk. Sorry, what was that? Did someone say something? No.
I just made a comment that is very interesting that will be trying to practice here in Canada.
Yeah, it's always a bit of a double-edged sword trying to balance research and seeing patients. I think sometimes if you don't get the balance right, you can end up being not so great at both. I think it's hard to call yourself a clinician scientist if you don't see patients, and it definitely makes you a better scientist if you are looking after men with prostate cancer. So as we were trying to think about what to talk about, Norm and I were brainstorming about topics for this presentation. We wanted to keep it quite clinical and not too much science, given that there's been previous speakers in the past. And this is some of the lists we came up with, PSMA PET and lutetium, which you've had a talk a couple of months ago. And stereotactic radiation I'll be talking about. And if you look at these topics, it's hard to find a common link throughout this. And it took a while to think about our approach here. But I settled on treatments that don't directly target androgens. And so specifically don't directly target testosterone. And I think that this audience would be very aware of the side effects that can occur with androgen deprivation therapy, especially long-term treatment. So it's good to have a discussion about what are the ways that we are trying to spare our patients from these long-term toxicities that can occur with ADT. So I want to take a step back and look at just have a brief refresher about prostate cancer disease states. So most men will be diagnosed, as we're aware, with clinically localized disease. So and what that means is that the cancer is confined to the prostate or maybe some nearby lymph nodes. And the great thing about this is that well and truly a vast majority of these patients will be cured with a combination of surgery and radiation therapy. These are associated with side effects that many of you would be aware of. Unfortunately, a small proportion do have encounter a situation where surgery and radiation itself is not curative. Some years later, or even a short time later, they can have a rise in their PSA tests. And this kind of signals that there may be some leftover prostate cancer elsewhere. Left unchecked, this can eventually progress to a point where the prostate cancer spreads elsewhere to other parts of the body away from the prostate. And we know these are called metastases. And there's been a very, very strong history over the last 70 years looking at trying to deprive the body's production of testosterone and other androgens through ADT. And that's been remarkably effective. But eventually there is a situation where the cancer becomes resistant to these therapies. And traditionally, maybe up until 5 years ago, we were using all our best treatments, all our tablets and chemotherapies at the very end. And that kind of needed a change in thinking over the last 5 years. So these last two states here, which I'll be focusing on today, are metastatic hormone-sensitive prostate cancer. So that is, the cancer is sensitive to depriving the body of hormones. So the cancer shrinks as a result of less hormones being in the body. And then as it becomes resistant, we get this metastatic castration-resistant prostate cancer. And if we kind of follow how this tracks across, these entities that I've mentioned, metastatic hormone-sensitive prostate cancer and metastatic castration-resistant prostate cancer, it's really the castration-resistant prostate cancer, which is the so-called lethal form. So up until that point, all our other medical conditions that we deal with are competing with the prostate cancer for our long-term well-being and survival. But when you reach that castration-resistant prostate cancer stage, that's when prostate cancer, I explain to my patients, becomes your biggest problem and outweighs things that may take a bit longer to develop complications from. So for example, if you have diabetes or high cholesterol or heart disease, it's not to say that those things can't affect you really quickly, but at the same time, some of the complications that occur are more long-term. So I think the key when I take a step back is to really trying to make sure that we keep patients with advanced prostate cancer in this hormone sensitive period for as long as possible. And we'll be talking about ways to do that today. So really treatment has exploded in the last 10 years. And that's really what drew me into the looking after prostate cancer, men with prostate cancer. Back when I started in sort of 2010 as a junior doctor, we really didn't have too many treatments. And at the time, abiraterone and enzalutamide, you'll know them as Zytiga, or I'm not too sure what the other brand names are in Canada, but they started to come on the market. But since then, number of treatments have come about, lutetium being one of them, immune therapies, radium you may have come across. And about 5 to 8 years ago, we started to move these drugs early on. We basically challenged the dogma to say, okay, the treatments work at the end, but it's not, they don't work that great. The cancer has become a more resistant beast at that point in time. It has lots of different components. Maybe if we can get into it early before it starts to mutate and gain a foothold, maybe we can hit it then. So a lot of therapies have now been proven, hormone therapies have now been proven to work in earlier disease states. So every one of the green agents here are the hormonal therapies, and they're remarkably effective. And I'm not here to challenge that, but to try and figure out if there is an alternative. So here's a statement here: sustained suppression of androgens is the cornerstone of how we look after patients with advanced prostate cancer. But is there a better way? You know, is there an alternative approach where we can reduce some of the toxicity and not overtly compromise the long-term effectiveness of these drugs? You know, I think it's, with all these treatments, it's always been a balance of, okay, how do the patients feel? We may be trying to give the best treatments up front, but you know, what effect does that have on quality of life? And I think some doctors, and it's taken a number of years to try and better appreciate what is a reasonable trade-off to make. I think sometimes what we see as a reasonable trade-off in terms of side effects and increased time with this condition and living longer may not be what this audience believes. You know, that I think there can be a disconnect between what's important, and that also differs from patient to patient. So quick biology lesson about how hormones are made. So there's a number of structures in the brain, including the hypothalamus and pituitary, and they release some hormones, which I won't go into huge depth about, but the end result is producing testosterone from and androgens from the adrenal gland and that sit on top of the kidneys, as well as the testes. And the way our drugs work is that they try and put a circuit breaker high up where this signaling starts to begin. And that kind of cuts off the supply of producing testosterone, as well as other androgens. Even our newer therapies that I mentioned there, about abiraterone and enzalutamide, they're called the second generation androgen receptor inhibitors. So this usually, when we make testosterone, it goes into the prostate cancer cell. Can you see that okay? Has the screen gone funny, or is still going okay for you?
Yes.
Black? No, okay, great. Hopefully just my screen then. Has gone into the prostate cancer cells. And let me just, coming up funny on my screen. Let me just stop and reshare. There we go. It binds to this androgen receptor in the prostate, and it basically tells the prostate cancer cell to grow uncontrollably. And our drugs, like abiraterone, are used to decrease the amount of these hormones in the body. And our other drugs, there's a number of them now, are trying to compete for that receptor, to try and outcompete that little binding pocket there where the drug acts. So it tries to, where testosterone usually binds there, these drugs now compete for that binding pocket. And the reason why all this matters about how, like, this continual push to treat prostate cancer by lowering the body's testosterone, is that we're aware of the immediate and sort of more longer term side effects. Many of you who may be on ADT have experienced these different troubling and at times very troubling side effects, including hot flushes and hair thinning and very, and at times very profound mood changes. But at the same time, as our treatments improve and men do live longer, we're starting to see a huge wave of these other more long-term side effects that can occur. So weak bones that can lead to non-cancer related fractures, and a change in our overall sort of cardiovascular health that you can see there. And they're collectively known as the metabolic syndrome. So, increased weight gain, high blood pressure, high cholesterol, developing diabetes, and ultimately all these things come together and increase the overall risk of heart disease, being at a higher risk of heart attacks, higher risk of stroke. So how do we sort of start to deal with this? And I don't think Australia is special in this regards. I was looking at that Life on ADT website, as I'm unfamiliar with Canadian programs, but I think it does take a multidisciplinary approach. Some of you may be in touch with very similar programs in Canada. So in Australia, the Prostate Cancer Foundation funds a number of prostate cancer specialist nurses who help with these side effects, including the counselling, including the guidance of how to manage some of these side effects, linking them in with the hospital programs. So one thing that occurred where I work, Monash Health in Melbourne, is that as I was going through, the endocrinologists, so these are the doctors that usually look after diabetes and usually look after osteoporosis, they said, hey, look, there's an amazing opportunity to contribute here with prostate cancer care. And a lot of those side effects are to deal with hormones. The endocrinology is about hormones and how they're regulated in the body. So they became really experts, and I feel like this is important because it takes some of the pressure away from me in the clinic. Not unsurprisingly, patients do want to talk about certain other things related to their treatment, and that can take up a huge amount of time. And these long-term chronic side effects, they either get ignored or severely underappreciated and under-discussed. There's an awareness now by industry support programs. So, I mean, some of the injections that the ADT injections, the companies that make these injections, there's been a big push to try and help with support programs and linking patients in with community exercise physiologists and psychologists to try and deal and address this metabolic syndrome up front. So that's sort of the supportive aspects, but what can we actually do with our treatments? Not just what we give, but how we give it as well. And one approach is to say, how about we don't give the ADT continuously? Is there a way that we can say, okay, pulse it on and off, and importantly, try and figure out if that we can minimize any detrimental effects on long-term well-being. So here's a study that recruited over 1,500 patients, and it took many. You can see that the follow-up there is out to 15 years that they tracked these patients, a monumental effort. And we can see that there's a line of patients that were on continuous ADT and a line that were on intermittent ADT. And the way intermittent ADT worked is that you aimed for a very low PSA. You kept patients on ADT until they got to a very low PSA. And if they held that for a certain period of time over a number of months, what we did is that we stopped the ADT and we watched. And we watched how they were feeling, and also their PSA levels. And what this essentially shows, what the study tried to show is like, was there any detrimental effects? So it wasn't to try and say, is intermittent therapy better than continuous therapy? Was there any detrimental effect? And cut a long story short, it looked like in the right patient, in a very carefully selected patient, pulsing the ADT on and off and allowing the body to start to make testosterone again when ADT had been stopped, didn't lead to any major overt differences in long-term survival. So this is what I incorporate in my own practice now. You know, if patients have been stable with a very low PSA on ADT for a very long time, and you know, that's all. And these things like long time, they sound vague, but it's always a discussion. You know, I don't consider it before, say, 6-7 months of stability of PSA, but then definitely at the 12. If someone's been on continuous 12 months of ADT and things are looking, PSA is well suppressed, I will often at least say, let's have a bit of a discussion about this, especially if they're struggling with the side effects that I mentioned before. The issue is that when you stop ADT, it's kind of like these drugs that we use to control testosterone, they put the body's own production of testosterone to sleep. And trying to wake that back up is a major problem. So this is a study that was published a couple of years ago now, where they tracked over 300 plus patients and looked at how long it took for patients to recover their own body's testosterone production after they ceased treatment. And you actually, unlike all the other curves that you have probably seen before, usually the lower line is the bad line, but in this situation, think about it the reverse way. So the lower line is the line that you want to be on, because it means that your testosterone production is starting up quicker. And there's two main relationships here. If you're of an older age, then these drugs put your own body's production of testosterone to sleep for a longer period of time. And the other factor here is that the longer you're on it, the longer you're on ADT, the more likely it will take the more time it will take. So these are the things that we consider. We can say, like when I say to a patient, okay, we're going to stop ADT, some patients are still going to have low testosterone, even though the drug is not in the system anymore. And in fact, look here, at 25 months, so that's like 2 years after stopping ADT, there's about, what have we got there? We've got about 20% of patients, 1 in 5 patients, who still have not recovered their testosterone back to their normal levels. So they are going to be at risk of all those short-term side effects, as well as those long-term side effects as well. So what about a different approach? How about we find drugs or create drugs that do a better job at recovery? So when we stop these medications, our own body can recover quicker. And that was the basis of a study that was published a couple of years ago now for the HERO trial. And all the ADT that has predominantly been used to date, in fact, all the ADT has been predominantly used to date has been injection form. And one of them is Leuprolide, or the brand name here, I think, is Eligard. And this tested patients with advanced prostate cancer and gave them an oral therapy. It's almost like the injection, but in oral form. So, but the difference being is that with an oral tablet, you have to take it every single day. Whereas with the injection, once you have the injection, it's with you. That many of you have actually felt that the pellet underneath the skin, and that's releasing the drug continuously over a 2 to 3 month period. This is looking at an oral drug to do the same thing, and they were interested in a number of things. But firstly, how did it compare to the injections? No use having an oral drug if it's not suppressing the testosterone sufficiently. And then the second part of the study was to say, okay, at about 1 year, we're going to stop both drugs and see what happens with how quickly the testosterone recovers. So first thing, and the key result here is that, that I found surprising is that I often tell patients, oh, look, you're on the injections, continuously every 3 months. That should be suppressing your testosterone levels very well for for all that period that you're on it. But we can see that's not the case. So with the injection, it's small, but there is a 10% of the time, about 12% of the time, where you're actually in a situation where there is enough testosterone to potentially stimulate prostate cancer growth. And the oral tablets are far higher. So there's an 8% difference, and this was found to be much superior to the injections. Next thing, key point, was that the tablets worked extremely fast. So we can see that by even less than 1 week, the testosterone is plummeting. So, I think if patients need treatment very, very quickly to try and control their prostate cancer and can control the hormones, the tablet form can be very rapid in its onset. And finally, I mentioned recovery. So once you stop the drug, so the end of treatment was week 48, you stop week 49, you stop the drug, how quickly does it does testosterone level start to rise again? And we can say, even at a month, you're starting to improve, but the injection is still hanging around, that black line here. But at 2 months, you've got even higher recovery. And essentially at 3 months, when you would have received the next injection, your body's own production of testosterone is back up to normal. As I mentioned before, cardiovascular side effects with long-term ADT are a huge problem. Well, does this tablet do anything about that? And it looks like it does as well. It looks like it halves the risk of having a major cardiovascular event. So usually that's something like something that could hospitalize us. So a heart attack, a stroke, and what was particularly interesting is that if you had existing heart problems, if you had a prior mini stroke in the past, that difference became very, very profound. So you can see there, it's a 15% difference in overall risk. So this is a drug that is in Australia not been approved yet, but it's definitely in clinical trials now. This was a major clinical trial. I think in America it is available, and I'm not too sure. I don't believe it is available in Canada just yet. So I want to pivot back to metastatic hormone-sensitive prostate cancer now and talk about that. So just to clarify again what the definition of that is. So we're talking about before the cancer becomes resistant to ADT injections, and we're talking about metastatic prostate cancer, so it has spread to other organs. Now, my background as a scientist in the lab is I get to see both sides of how development is going in terms of what are the scientific breakthroughs we're making, but then also what is being, I guess, translated into how we actually look after patients. And, we've come a long way with scientific research, but at the end of the day, at the moment, somewhat disappointingly, we are still using scans to determine how we look after patients. I think that is one piece, and Cameron Herberts next month will be talking to you about the genomics parts of it and how that can be integrated to how we look after patients. But one way we decide how to look after metastatic prostate cancer patients is decide on disease volume. How much cancer do you have in the body? Do you have a low amount or a high amount? And high means they've drawn, many groups have drawn arbitrary lines. They're trying to count the number of spots that are relevant. But I think we look at this scan here on the left and we go, look, that's a fair amount there, black being the areas of cancer growth. And the other where we say high volume is if organs that don't typically get affected by prostate cancer, such as the liver and the lung, we also classify that as a high volume. I want to marry that up against another term. So we're talking about volume, but then what about when we develop these metastases? So there's what we call synchronous and metachronous. And synchronous is essentially when you're first diagnosed, you've never had any treatment for the actual prostatic itself. There's been no radiation or no surgery performed. And at that point in time, you already have distant spread of the cancer. So that's what we call de novo metastases or synchronous metastases. And that's surprisingly very, very different to a situation where you were diagnosed many, many years ago and you've had your prostate out or you've had radiation treatment, and only then do you develop metastases some years later. So we can see that there's an empty circle there, a hollow circle saying that's the treated or an active disease. And knowing how these play together, so we've got two variables, how much cancer is about, so the volume, as well as whether or not you've had any prior treatment to the prostate itself is important. So we can see lots and lots of lines here, but I'll try and point out the main take-home message is that, not surprisingly, if you had your prostate cancer treated in the past and then you develop metastases some years later, and combining that with not having a lot of spots on the scan, those patients do the best. And on the other end of that is having a high volume amount of cancer, and as well as being diagnosed with metastases at the first point where you were where you received the prostate cancer diagnosis. Those patients are of greatest need of getting the whole kitchen sink thrown at them in terms of our best treatments up front. So the blue line is somewhere where we can intervene. You know, is this a situation where we can start to talk about something like that is becoming a hot topic in the field, a phrase known as treatment de-escalation. So doctors, I think, are very good at, and a lot of these trials are about treatment intensification. So how do we add more treatments? But more treatments invariably, not always, but can lead to more side effects. But in the right patient, and that's the thematic part of my talk, in the right patient, can we delay throwing all our treatments without compromising long-term well-being? So maybe there's a state of cancer that is somewhere between having no metastases and this other side where there's spots everywhere. And then this middle state here, this oligometastatic state. Is this a place where we can intervene and give radiation therapy and what we call metastasis-directed therapy to try and improve outcomes? So this is holding off on ADT. Can we directly treat the metastases with something like radiation treatment? And this is where I talk about stereotactic radiation. So just a bit of a background and basics of radiation delivery. For many, many years, we did what we call conventional external beam radiation. So think about this as, it's a gross oversimplification, but think about this as radiation sort of from one area. So you're kind of shooting radiation towards a target, but you're shooting it from one direction. What if we did this? Sorry, just having trouble with my computer again. What if we, rather than having one direction that we're shooting from, what if we combine multiple different directions and that starts to add up the amount of radiation that's delivered? So we've got to make sure that we have that we keep the tumor area very well defined. But what if we come at it from multiple angles and treat with a higher dose and making sure that we spare any normal tissue and normal parts of the body away from our radiation? Radiation causes side effects as a result of our healthy tissue being affected. And that's where stereotactic radiation comes in. So we deliver a higher dose. Pleasingly, it's less treatment. So some of you who may have had radiation in the past, it could have been 5 treatments all the way up to, say, 30-something treatments. And we know that adds up over time. But with stereotactic radiation, it's usually less treatments overall. we balance this against needing a greater level of expertise. So not everyone knows how to, is experienced to draw these and control the dose and do all this mapping to ensure this approach is as safe as possible. You can imagine if we're now dealing with higher doses, you have to be even more careful with how you're doing it. It does require a lot of labor is involved, and overall side effects for the patients who I have referred on to have this treatment done. Overall, the side effects are generally favorable. There are exceptions though, depending on where the cancer is. So, anywhere close to the brain or the neck area, those places can be more nausea. They can cause more nausea when these treatments are administered, but further away when we're treating lower spine or even the prostate itself, side effects appear to be at least comparable, if not a bit better than other conventional radiation approaches. A couple of months ago, you heard a talk about PSMA, and this is linked to the lutetium, and this is sort of the final third of my talk, looking at PSMA. So PSMA stands for prostate-specific membrane antigen, and we know that in prostate cancer, it is overexpressed. So that means that there's a lot of it on the surface of the prostate cancer cell, and as the ADT resistance occurs, we get a lot more of this on the surface of the prostate. It says prostate specific, but strangely enough, some of the side effects of lutetium treatment that we see are because PSMA is also found on a number of healthy organs as well. It's in the salivary glands. You may read that these treatments can cause dry mouth and a number of other issues. And using PSMA to change the way we scan for cancer has been nothing short of revolutionary. So this is a patient who I looked after, overall very low PSA, and we can see that 2.6, a bone scan and a CT scan in this gentleman didn't show anything. So this little black area is where the dye went in. This is some arthritis in the knee, some arthritis in the shoulder itself. But for all intents and purposes, the interpretation of this scan is a normal scan, and CT scan didn't show anything either. But that same gentleman who we put through a PSMA PET scan, we can start to see, I talked about salivary glands showing up PSMA, so that's not cancer in the head itself. We pee out this dye, so it's collecting in the kidneys as well, and it's also collecting in the bladder, so that's not cancer in the bladder or in the kidneys, but we see this area here. That's not meant to be there. And we can see when we cut through the scans that these are prostate cancer cells that have found their way into lymph nodes in the abdomen itself. So we're going to combine things now. Let's say we give the stereotactic radiation therapy, and we're now seeing cancers earlier with the help of these PSMA PET scans. Can we use that to guide where we give this high dose radiation? And two trials have been doing that, and they specifically asked the question, can we delay ADT commencement? And it is full credit to them to try to embark on this study. It is against the central dogma. We're inclined to think we have to start treatment as soon as possible. But as I mentioned, in the right patient, can we delay? And what we see here is that in the arm that just got closely watched to see if their PSA was rising, to see if they developed new spots, in about a year's time, they ended up needing to start treatment for sure. They had very strict criteria about when to start. But in the group that got stereotactic radiation to a maximum of 3 spots, so we're talking about that oligometastatic state where you've only got a few spots. This is not for the gentleman who's got cancer in multiple areas. You end up playing whack-a-mole trying to get to zapping all those spots. But if you've got a small number of spots, it looks like you can potentially delay ADT for a considerable amount of time. And that's been replicated in a couple of studies. So I think the conclusion here is to say it's safe. It's clearly safe using high dose radiation to treat multiple spots. But whether or not that the question remains in the field is to say, how does that compare to starting ADT straight away, starting the other hormone therapy straight away? I'm not saying, once again, I'm not saying don't do those things, but what if there was a period of time where you have got spread of cancer, but you play this, you try and zap these isolated spots and get some control, and delay the need to start. Eventually there will be a need to start these treatments, but can that be delayed for a period of time where we can keep quality of life up as much as possible? So a couple of months ago, you heard the lutetium talk, and we can, I'm mindful of time, so we should also sort of leave some time for Q&A. So these are two studies that one of them was mentioned. This is the VISION study. The other big study in this space is the therapy study, an Australian clinical trial that I was involved in as a principal investigator for. And you know, we, as mentioned earlier in the meeting, it's now FDA approved, and we've seen some remarkable pictures of. So this is almost like a painting of where the prostate cancer is before and after treatment. Obviously, this is cherry picked, right? So we have to, you know, we got to be. I think it's important that as a scientist and as a patient to be skeptical and to read about the evidence, make up your own mind, but it is possible to have these dramatic effects, and certainly I do recall those patients very well. And one of the things is that repeat treatments are feasible. So on this particular study, if you had a really dramatic response to the first couple of treatments, you actually were allowed to stop. And the reason being is that, you know, we never want to do anything that could potentially cause harm. Every time we give an infusion, however innocuous that we believe it to be, there is a risk that something untoward happens that we never expected. So we definitely want to treat, but not over-treat. And this patient had a dramatic response in their PSA and stopped treatment for a bit. And then as the cancer came back again or started to grow again, they got successive treatments. And you can see that the lines do get closer together. So, not for a second do I doubt that like all treatments, resistance can occur and the effectiveness wanes over time. But this is in a patient who had, as you can see, all the treatments previously. So my experience in Australia is that things are improving. This is one of the questions that was asked earlier in the meeting, is as we start to get greater access to lutetium, both in the US, now that it's FDA approved, and eventually in Canada, what does that mean for the local practitioner who is using it for the first time? Well, thankfully, as discussed, there's very well tried and true methods that are being shared in the community. There was a big conference recently that's called the PROSTIC, PROSTIC, PROSTIC conference, and that you can go online to watch the videos. I can share some of the links there. And essentially, it was a global event that was trying to start to share our knowledge of how do we quality control this, so that if you're getting lutetium in Australia, it's the same as if you're getting lutetium in Europe, and it's the same as if so there's got to be these checks and balances and rules, and certainly these people who are the leaders in the field are coming together and deciding on what is the minimum, what is the criteria that we will hold ourselves by. At the moment in Australia, it's still restricted to large cancer centres. The wait times are variable, and not surprisingly, as it is probably in Canada as well, clinical trial participation is what I always try and encourage in my patients, because it's a way to try and get access to these medications, which can take a long time to get funded. So that's something to keep in mind. Finally, I want to talk briefly about DNA repair. So you've had similar talks in the past, but our body is always replicating DNA as our cells divide and grow. But we, due to radiation and other sort of free radicals, we can get damage to the DNA. And we have a bunch of machinery in our body that repairs these breaks, these single strand breaks and these double strand breaks in the DNA. And one of those that you've heard is BRCA2. And for the sake of time, I want to leave some Q&A time, but like we're starting to see this melding of these treatments in lutetium together with our genomics. We see these remarkable responses in certain genomic subtypes. So this is a patient who had lost both copies of their BRCA2 gene in their tumor. And these patients appear to benefit most from lutetium PSMA. That's not to say that if you don't have this, that you don't benefit, but that's something to keep in mind as we start to play that out in the scientific world. So that's sort of my talk, trying to find a way to pull these things, these seemingly somewhat initially unrelated, but over time it became obvious that there's a story about trying to spare long-term or even short-term toxicity for our patients using some of these methods. And these are a couple of slides that I threw in at the end that weren't in the talk. I think someone asked whether or not these trials are being done so with other agents, and we're now in Australia. These are all Australian studies. That I've been involved in. So this is a PRINCE trial. Can we add immunotherapy to lutetium? Can we add PARP inhibitors to lutetium? My old supervisor, Professor Arun Azad, during my PhD, is saying earlier in the disease state, where before castration resistance, before resistance to ADT is being occurring, can we add lutetium then and combine it with chemotherapy? And finally, even earlier than that, one of my mentors, Professor Declan Murphy, and colleagues are looking into lutetium prior to surgery. So this is right at the start now. It's something that's in our high-risk patients. So, if you have if there ever is a garden variety prostate cancer, but if you've got high-risk features, the biopsy looks bad, looks aggressive, does a bit of lutetium before you have your prostate taken out. These are being active areas of investigation. So I want to thank all the members of my lab who I sort of quizzed to try and bring together a talk that was hopefully helpful to this group. And just wanted to invite questions or comments and experiences of what's happening locally. Thank you.